Good afternoon, everybody. This is Dr. Michael Jacobs here at the Fertility and IVF Center in Miami, and welcome to our Monday afternoon Instagram chat. Today's topic is how do I get pregnant if my partner's sperm is not working that well? So, as you realize, fertility requires three main things. It requires good quality eggs, it requires some good quality sperm, and it requires a uterus that can have an embryo implant and give birth and have a child from. So, when we do a basic fertility assessment, we're looking at the ovarian reserve of a woman. We're making sure her tubes are open and the uterus is normal. We're making sure she ovulates. All that is okay. We do a sperm count on the male partner, and we find out that that's not so normal. So the first thing we try and do is look at, is this a consistent thing, or is it just a one-off time that it's abnormal? We try and get at least two samples separated in space by at least a week or two to see what the pattern of it is. And when we look at sperm, we look at the count, the motility, and the morphology of the sperm. These are the three key ingredients. One, how many are there, the concentration of them. The second is what percentage of those that are there are motile, how many are actively moving around. And the third is, what do they look like? Are they normal in shape or not? And if you have a deficiency in any of these three areas, it can make it more difficult for the sperm to naturally fertilize an egg or even find the egg. Because remember, when ejaculation takes place, the sperm is up in the vagina. It's got to swim its way through the cervical mucus up into the uterine cavity, find the opening of the fallopian tube, go up into the fallopian tube where the egg hopefully has been picked up by the tube after ovulation, and then fertilize the egg. Once it forms an embryo, the tube transports that back to the uterus where the embryo then implants and continues to develop. So what happens when those aren't normal? Well, the first thing we try and do is look at, is it a consistent finding? If there's low counts, we'll often do some hormonal testing to measure testosterone, FSH, LH, the reproductive hormones on the male side, to see whether there's any benefit of trying to boost any of those. And a word of warning is, the main thing is, please do not take testosterone if you're a male with a low sperm count, because that can make it a lot worse. There's other things that we can do to try and improve the environment for sperm production, but taking testosterone or bodybuilding drugs or androgen in general is not a good one. If there's something that can be fixed, and we have plenty of time, if the woman is 33 years old rather than 42, then certainly we can wait a few months and see if treatment in any way results in improvement of the sperm. If there's an anatomic lesion like a dilated vein called a varicocele, sometimes repairing that may help, and sometimes it doesn't do a whole lot of good. So that becomes more of should we or shouldn't we approach an anatomic lesion on the male side. But let's assume it is what it is. The sperm is just not normal. How do we get the sperm to work? And we've got really two different ways to do that. The first is to consider what's called intrauterine insemination, formerly called artificial insemination. And this is just in the process of identifying when ovulation is occurring, most commonly using a fertility drug on the female side, such as Clomid, letrozole, or injectable medications such as gonadotropin, sometimes a combination of the two. And by identifying when ovulation is occurring, and preferably by having 2 or even 3 eggs ovulate in the middle of the cycle, we can take the sperm, jazz them up in the dish in the laboratory, and then at the time of suspected ovulation, to inseminate in the uterus so that the sperm don't have as far to go to find the eggs. And once the egg is ovulated, it's probably good for fertilization for a 24-hour period. But if someone has really low sperm, ejaculating in the vagina, a lot of that sperm might not live long enough to find the egg at the right time. So what we do is we prefer to have you on a fertility drug. We trigger the release of the eggs at a specific time, and around 36 hours after that ovulatory trigger, which is in the form of Ovidril or HCG, we can inseminate with your partner's sperm. So the sperm is washed in the lab. We isolate the best sperm. We identify the sperm, and with a very small catheter can place that up into the uterus so that the sperm don't have as far to go to find the eggs. The good part about this, it keeps things somewhat natural in that the sperm is still fertilizing the eggs on their own. The good thing is that it's bypassing a lot of the traveling the sperm has to do. It's kind of, if you're swimming from Miami to the Bahamas, it's like starting out, almost in the Bahamas instead of having to go across the whole bay and the ocean. So you get a lot closer to the sperm, but even if the sperm is put up into the upper part of the uterus with an insemination catheter, the sperm still has to find the opening to the tube. It's still, and they're random. They don't like, oh, the tube's over there. They're just kind of running around in circles trying to make progressive movement, and some of them hopefully luckily find a way out the tube and find the egg to fertilize it. And that's why you need millions of sperm to fertilize an egg, basically. It's not a very efficient system. So the sperm have to get up into the tube and fertilize it, and then we wait and see if pregnancy has occurred by doing a pregnancy test about 2 weeks later. When we use HCG to trigger ovulation, ovulation will usually occur within 36 to 40 hours afterwards. Occasionally it might be a couple hours before that, and occasionally a few hours later. But that allows us to get the most active viable sperm in the right general location, so it can find the egg at the time that the egg ovulates and is most fertile from the standpoint of being receptive to being fertilized by sperm. Insemination rates are going to depend on what we're treating, basically. In most times we're either treating a low sperm count or unexplained infertility, and we're not going to have tremendous good success rates. If you look at a normal couple trying to get together, their natural pregnancy rate per cycle for somebody under age 40 is about 18% a cycle. When you have low sperm counts, you're not going to get 18% pregnancy rates with insemination. If you had somebody who just couldn't ejaculate properly, that's about what you get. But if you have somebody who has a low sperm count, the pregnancy rate for insemination is going to be pretty much related to what the sperm quality is. If you have unexplained infertility other than the sperm count being low, and you do inseminations with normal sperm and a fertility drug, you only get 8% with Clomid, and if you get injectable fertility drugs, it might be 15%. So if you're doing inseminations for a low sperm count in a male, normal sperm count would be at least 15 million sperm per cc of fluid. It'd be 40% of the sperm being motile and 4% being normal in shape. If you have less than that, you're going to have lower pregnancy rates. So with oral fertility drugs like Clomid and IUI, you're looking at only about an 8% pregnancy rate at best. And if you have sperm that are in the 10 to 15 million range, it's going to be no better than 5%. And if you get down with sperm counts below 2 or 3 million, it's rare. It's 1-2% that you're going to see pregnancy rates, which means we'd have to do this 50 times, which if you think about it, that would mean doing an insemination a month for 4 years to get somebody pregnant. That's not a very good way to treat anybody. It's expensive, it doesn't work well, and so inseminations work best in a man who has a slightly suboptimal sperm count, preferably in the 10 to 20 million range. Sometimes you'll see success in the 5 to 10 million range, but when it gets less than that, particularly if you have low motility and low morphology on top of a low count, it becomes pretty rare that we see success, but it can be a first-line approach. The better approach is in vitro fertilization. Now with in vitro fertilization, what you do is you put the woman on injectable fertility drugs to produce multiple eggs. We'll usually end up in a young person, hopefully with 15 or 20, but even in somebody, 37, 38, we try and get 10 or 15 eggs. Sometimes we're able to do that, and sometimes we're very limited based on the reserve in the ovary. So we get whatever eggs we can, whether it be 4 or 5 eggs in somebody 42, or whether it be 20 eggs in somebody 25. Whatever eggs we have, hopefully the most of those are going to be good quality, or what are called mature eggs, basically. and those are the ones that we can fertilize in a dish. And when we fertilize eggs for low sperm counts particularly, and in general just to ensure fertilization is occurring, we usually will do what's called ICSI, or intracytoplasmic sperm injection. And what this does is at the time of ovulation in the middle of the cycle, when you get these eggs out, you take the sperm, process it in the lab, just like you would for insemination pretty much. But instead of just taking the sperm, putting it up in the uterus and hoping they find their way to where the eggs are, you actually take a very small glass needle and micro-inject that into the eggs. So you don't need a whole lot of sperm. If you only have a dozen eggs that are good quality eggs, we need a dozen sperm that look like they're alive and swimming. And you isolate the sperm and inject it into the egg, and a reaction takes place and the egg fertilizes. So the big benefit of IVF is not only are you getting the egg and the sperm in a dish together, and prior to having ICSI available, that's what we did, but we found out that even though you had lots and lots of sperm, 50 or 100,000 sperm per egg in a little micro droplet in a culture media, a lot of those sperm won't fertilize the eggs on their own. So even though there might be a reasonable number of sperm from IVF, in men with very low sperm counts, they don't fertilize well, and you want to micro-inject the eggs with intracytoplasmic sperm injection. And by doing that, you basically get the same fertilization rate that you would as if the sperm was normal. So we've totally bypassed the issue of egg pickup, the sperm finding the egg, the embryo getting transferred back into the uterus. We're able to get the same normal fertilization rate of an egg of a normal, healthy male person by doing IVF with ICSI. What happens after that is you let the embryos develop, and on the 5th day of development, you can either transfer the embryo, or as many patients choose, to biopsy the embryos to make sure that they're genetically normal, and then select the normal embryos to transfer back into the uterus. Now, IVF success rates, if you put one normal embryo into a normal uterus, you're going to have a 50 to 60% pregnancy rate, irrelevant of the age pretty much, as long as you have a normal embryo to transfer. So IVF success rates, even with low sperm counts, are very good as long as you have a normal embryo to transfer at the end of the day. The low sperm counts don't cause abnormal embryos per se, even in men with no sperm in the ejaculate, so-called azoospermia, which can be due to either a past vasectomy procedure, it can be due to past surgery, it can be due to a blockage in the system. If you have a male where we can get sperm from the testicle directly, even though that sperm is not as motile as ejaculated sperm, it's not good for insemination when you get sperm from the testicle, but you can get sperm from the testicle from either obstructive azoospermia, meaning normal sperm production, but a blockage in the system, or you can get sperm from a male from the testicle who doesn't have any sperm coming out in the ejaculate, and even though the tubular system may be functional, the testicular production of sperm is just so poor that we're not seeing anything in the ejaculate. But as long as we have identifiable live sperm in the testicle, that sperm tends to work. If it's just twitchy sperm from men with very, very low sperm in the testicle, we might see a lower fertilization rate even with ICSI. But again, as long as we get a normal embryo at the end of the day, we're going to get that 50% pregnancy rate in an IVF cycle. The alternative, if there's no sperm in the testicle at all, or a couple prefers to be treated with just inseminations, even though there's no sperm in the husband, then you have to use donor sperm, and we don't have any other alternative. So, in short, it comes down to, do I want to use the donor sperm or my partner's sperm? Most people want to use their partner's sperm. And then the two steps are either intrauterine insemination with an ovulatory drug, if the sperm counts are reasonable, and if the woman is not too old, if their ovarian reserve is good, But if you have somebody who's older, particularly if there's diminished ovarian reserve, even in a younger person, you don't want to wait 3 or 6 months to see whether inseminations are going to get lucky, because no matter what, we don't get great success rate with IUI. It's certainly much, much better than doing nothing, but nothing compares to the practical application of IVF with intracytoplasmic sperm injection for male factor. It is the gold standard. It's the Mercedes way of being treated. It works. It really is. You get to the end point, you get to the point of getting pregnant, having a baby so much quicker, and particularly as the worse the sperm is, the better IVF is going to work for you. So that's it in a nutshell. I hope it was somewhat informative this afternoon. As always, please stay safe and tune us in next Monday. We'll have another topic to address. If you have any questions, please feel free to call us. And if you're a patient of ours, we've probably already talked about a lot of these things. If you're not a patient of ours, we welcome the opportunity to serve you. So have a good afternoon, stay safe, and let us know if we can help. Bye-bye.